class of the Heart Failure University, and you guys have made it this far, so congratulations. Everybody's got big, broad smiles today. That's great. That's wonderful. I know you're like, phew, done with it. So you've gone through all the good parts, bad parts, not so great parts, everything like that. So today's the last session, and we're going to kind of end on a high note, and we're going to basically, it sounds like it's going to be bad because I'm talking about end-stage heart failure, but what we're going to talk about is the options that are available today, and we're actually going to celebrate modern medicine in a way that we have advanced this far to have these options available to all of us, all right? So I'm going to make this class very interactive. We actually have a few people who I'm going to use while they're here in the class to, ask questions to and things like that. I want to introduce a couple of people and myself. So first of all, I'm Dr. Pulakodal. I go by Telsa. It's a lot easier. I'm one of the cardiologists I work with, Dr. Kobalivkar. Him and I, we run the heart failure clinic here at Kaiser. We do two clinics, if he hasn't explained this already, but one of the heart failure clinics is here at Southwood, and the other location we have is at Piedmont Hospital in the specialty clinic over there. Sherry, who most of you have met already, is my right-hand person, and I'm sure she's probably talked to every single one of you at least once or twice on the phone, if not for more. Penny Anderson's joining us. She's with Thoratech. And we'll be talking about a device called an LVAD today, and she might have some more insight about it. And more importantly, we have Matthew Goodson, who you've probably met, and I'm going to pick his brain later, who's going to share some of his personal experiences because he's kind of gone through a lot of what we're going to be discussing today. All right? Any questions before we get started? And I do have a tendency to speak fast, so don't hesitate to interrupt me if you want, okay? All right. Pardon me? No, it's fine. I'll take care. All right. So today's class, I'm going to try and make it in a good 30 to 35-minute class. So it's going to be short, but I want the rest of the time to really discuss, people's experiences and any questions that you have in detail. Okay. So what we're going to cover today first is what is the definition? What do we mean by saying advanced heart failure? I mean, everybody talks about heart failure. When is it that we really say this is advanced heart failure? We need to do something a little more than just the usual medicines for it. We're going to discuss some of the devices that most of you may be familiar with, such as defibrillators. We're going to discuss what is biventricular pacemakers or defibrillators. We're going to talk a little bit about certain home infusion medications. These are medicines that you get to take home with you, but it's a continuous IV medicine, and then what those do and how those can help. Next, we talk about LVADs, or you may have heard of something called artificial heart pumps. It actually means a left ventricular assist device, and we're going to show some examples of that and talk about it. And last, we talk about heart transplant. All right, so a lot to cover, but actually it's going to be fun and interesting, I hope. All right, so let's talk about advanced heart failure. So, in the first class when Andy spoke with all of you, he discussed what heart failure was. Essentially, just to recap, the simplest definition I always say is when your heart is not pumping enough to meet the demand of the body. That's the simplest explanation for heart failure. Most commonly, it's because the heart is just not having a strong pumping function. It can vary from, almost normal, which is 55 to 60% is what's normal with each heartbeat, to really, really bad, 5%, 10%. And you can be anywhere in this spectrum. Now, what's important to remember is the term when we say advanced heart failure, to classify someone as saying you have advanced heart failure does not necessarily depend on that actual EF or the ejection fraction. I can assure you I have seen patients who have a pumping function of 30% and can't walk from here to there. And on the other hand, I actually have a patient whose heart function is 5 to 10%. He's 83 years old and he still runs a mile a day. So it does not necessarily correlate to that number. The number helps to know. Please come on in, sir. The number. Oh, it's all right. The number does help because definitely lower the number, the chances are you're going to have more symptoms related to heart failure, but that's not the only thing in the picture. It also depends on a lot of other factors. Okay? So when we talk about somebody with advanced heart failure, These are people who have had heart failure for, number one, a long time usually. We're talking at least a period more than several months. Very rarely we do see people who present for the first time and are so sick that we need to talk about advanced therapies, but that's the exception rather than the norm. Usually this has been going on for months, if not for years, and that's where they've reached this stage. And then most important is their symptoms. Like we talked about, this does not necessarily correlate exactly with the ejection fraction, but usually if it's really bad, less than 20%, and you've had it for a long time, you may reach a stage where the symptoms are so debilitating that you absolutely cannot live with it, despite all the medications, despite all the diet and the nutrition and all the things that you're doing. There are certain categories we like to classify people at. One of the simple classifications we use is called New York Heart Association. You may have heard of this before. It's also called NYHA. There's class 3 and class 4 symptoms. Class 3 is people who are comfortable at rest. While you're sitting, you're fine, you're not feeling any symptoms. But even small, very light activities, walking across the room, going to the bathroom, can make you really short of breath, can get you tired, fatigued. So that's basically where you're reaching class 3 symptoms. And class 4 is people who have symptoms even at rest. They can't even sit without feeling breathless. So clearly in these two categories of people, if they have been on maximal medical therapy, this is the category we would deem as advanced heart failure, and then we talk about these advanced options. The American College of Cardiology basically states stage D, which is like A, B, C, D. D is the last stage, are people with advanced structural heart disease and have marked symptoms of heart failure at rest, despite maximal medical therapy. And that is a big caveat. You want to try all the medicines first, as much as your body can tolerate. Again, this is limited by how much your blood pressure is doing, what your heart rate is doing, things like that. But as much as your body is able to tolerate, and if you still have symptoms at rest, that's when we talk about doing some further interventions. So let's talk about the first, most basic line of interventions. The first thing is simple devices. These are electrical devices that help with the heart function. The first one is an AICD, or ICD. It stands for Automatic Implantable Cardioverter Defibrillator. Most people, this is not necessarily an advanced heart failure therapy. This is more for people who have an ejection fraction, the EF, the pumping function of the heart, if it's usually less than 35%. Now, what we know is about 200,000 people in America die every year of sudden cardiac death. That's known. Most of these sudden cardiac deaths happen because their heart has gone into a dangerous and abnormal heart rhythm. You must have, at least the men in the crowd, you must have all seen basketball, and you've probably seen young kids when they're playing basketball, how they collapse on the court and suddenly they find that they've dropped dead. These are usually due to abnormal heart rhythms called ventricular arrhythmias. These are very dangerous because what the heart is doing is suddenly it just starts quivering. So instead of nicely contracting and pumping blood to the body, it just starts quivering. So essentially the heart stops. The only way to save somebody in that situation is by shocking their heart. You've probably seen it in movies and stuff. You shock the heart back into rhythm. What a defibrillator does is exactly that. It's a device that's implanted into your body, and all it does is monitors your heart, every single heartbeat, 24 hours a day, 7 days a week. It just monitors your heart lifelong. However, in that rare event, your heart were to go into that very dangerous heart rhythm where it starts quivering, then this would shock you back into a normal rhythm. Now, this is usually offered to people who've been tried on medicines for at least 3 months and their heart function has still remained less than 35%. So we do know those people are at higher risk for having the dangerous heart rhythm than somebody whose heart function is normal. Now, this does not necessarily mean once you get a defibrillator, it was going to shock. I mean, I have lots of people who go around their life, they have never had a shock from the device. On the other hand, I've had a few people who've been shocked 4 or 5 times, so they could have died, but this saved their lives. So the way I would probably put it, the best way to look at a defibrillator is like a life insurance policy. I hope that you never need it, but if you do, this is there and it could save your life. So with medicines on a good 3-month therapy, if your heart function is still weaker than 35%, that's when we usually offer this procedure called a defibrillator. It is a minor surgical procedure, as you can see. So I brought actually a pacemaker, which is similar to a defibrillator, but a defibrillator is a little larger than this, probably about that big and a little thicker than this device. What you do is, this is the actual battery or the generator. This is actually placed under the skin, right under your left collarbone. So they make a little incision in your skin, right under your left collarbone. They slide this into that area, that pocket over there, and they thread usually 1 or 2 wires down into your heart through a vein that's right there. So they're not going, doing any surgery on your heart per se. All it's doing is threading a wire or 2 wires from here through a vein into your heart. These wires basically monitor your heart, and if the need arises, it can shock your heart back into normal. So I'll pass this around. It's a very minor procedure, like I wanted to show you, but you can kind of feel it. Again, this technically is a pacemaker, but a defibrillator is just a wee bit thicker and larger than this exact device. All right, and then usually the battery life lasts anywhere from 5 to 10 years, depending on how often you needed to use it. And then once the battery is starting to kind of wind down and you need a replacement, these can be monitored. We monitor it every 6 months or so on an average. All it requires is another surgery where they make that same incision, take that piece out and put in a new piece right there. So again, minor surgery. It does not even require general anesthesia. It's done actually under local anesthesia, and as an outpatient procedure. All right. So any questions so far about the defibrillator? No? All right. Well, everybody knows it. All right. So another version of a defibrillator is something that we call biventricular pacemaker and defibrillator. Another term for it is CRT, or cardiac resynchronization therapy. So this looks exactly like what the device that I just showed you. However, the difference is, in a biventricular pacemaker, it not only is monitoring your heart and shocking it, it actually is pacing your heart. Not everybody qualifies for this therapy. So what happens in some people who have a very weak heart function, your heart has that right side and the left side. So usually in most people, both the chambers, the right and the left bottom chambers, the right and left ventricles, they contract simultaneously. They pump together. One side pumps blood to the lungs, the other side pumps blood to the rest of the body. But in some people who have advanced heart failure, the 2 pumping functions is asynchronous, where the right side may pump first, and then there's a delay, and then the left side pumps. So it's not pumping together in rhythm. It pumps one after the other. So in these people, because of that dyssynchrony, it's affecting the pumping function of the heart. That's why we sometimes put in a pacemaker that has an extra wire that will make both sides of the heart pump in harmony, pump together. So it kind of improves the heart's pumping function. Okay, does that make sense? So instead of one side pumping and then waiting and then the next side pump, this basically, we put an extra wire in where both sides can pump simultaneously and help with the pumping function of the heart. So the way we discover this is, again, it's in people whose heart function is less than 35%, and then we look at their EKG and we look for that delay. There's an electrical delay in the 2 sides of the heart. If you have that, then you qualify for this device. I would say the majority of people, sorry.
Can you repeat that, because my mind just went somewhere else?
Oh, not at all, of course. I do that all the time, don't worry. So what I was saying is, in some people, when their heart function is weaker than 35%, there is a delay in the function between the right and left sides of the heart. So instead of both sides of the heart squeezing together, the right side of the heart squeezes, then there is a delay, and then the left side squeezes. So this really affects the pumping function, how well your heart is working. So what this pacemaker does is, just like the defibrillator, it has a lead, a wire that goes in the right side of the heart. But in this particular device, we add an extra wire that goes into one of the veins behind on the left side of your heart. So there's an extra wire there. What that does is that it makes the heart, both the right and left sides, contract together simultaneously. So that can sometimes improve the heart function. And actually, in a majority of people, I would say about 70% of the people who get this device do state they have better symptoms, their symptoms are better controlled, they can walk farther, they can have more energy for activities. So it's not 100%, but about 70% of the people do get a tremendous benefit from this kind of procedure if you have that kind of delay. Now, the way we know that delay is through a simple EKG. We can look at an EKG and tell, is there that kind of a delay between the right and left sides? And if there is, then we talk about, getting this device. It does have the pacemaker and the defibrillator functions both in it. So sometimes people say this is the Cadillac device because it is the best one out there. And it's true. I mean, if you qualify for it, this is definitely a good device to get to try and resynchronize your heart. All right? Any questions?
Can I get one?
What's that?
Can I get one?
I'll have to look at your EKG. Any questions so far about this device or the defibrillator? Again, not everybody with the heart function less than 35% needs this. It's only in people who have that delay, and not everybody has the delay. Some people do, some don't. So, but we can look at it and we'll offer it. So this is another example of how the defibrillators, the biventricular defibrillators, put in the similar sort of box like we showed, and then we put the wires into the heart. You have two wires on the right side, and we thread the third wire behind the left side of the heart into one of the veins over there, and that way we basically synchronize the heart so the heartbeat happens simultaneously. All right, so both the defibrillator and the biventricular defibrillator, these are not necessarily advanced heart failure options. These are offered to people whose heart functions are weak if they qualify for it, even if your symptoms may not be that bad. So, however, the next several things we're going to talk about is for those patients who we have tried all this. We've tried the medicines, we've tried all the basic things, and you still have symptoms that are refractory, which means you really can't get on with your life. Even simple activities are being affected because your heart is so weak. And that's when we talk about the advanced therapies. So the first one we usually discuss is what's called inotropes. Inotropes is a class of medications that actually increase the pumping function of your heart. We've been talking about how the main issue with the heart is why the pumping function is weak. So with inotropes, we basically give you a medication that's going to increase that squeeze of the heart. It's going to make the heart squeeze harder. Now, it sounds great, and it actually does work. I mean, once people are on it, they suddenly feel like they have all this energy, and they feel like, oh, great, now I can do all these things I couldn't do before. But there is a couple of caveats to it, very important ones. Number one, it is not a life-prolonging measure. No study has shown these medications will make you live longer. And in fact, there may be even a slight tendency for increased death because of arrhythmias, irregular heart rhythms. So it's not a perfect medication. Hence, we use it almost always as a bridge to some other therapy, to buy time, to see, does this actually make you feel better? Because if it does, then that makes us feel a lot more confident. Maybe the other therapies such as an LVAD or a transplant may be right for you. So we use it as a bridge. Rarely, now if somebody is 87 years old and you don't want them to go through another surgery, I may use it as a home therapy for the rest of their lives, just to give them enough energy to go about their life. But again, we're not planning to do any surgery in them. But almost everybody else, the majority of the population that we use these therapies on, either it's temporary for a short period of time while you're in the hospital, or we use it as a bridge to a transplant or a bridge to an LVAD. So it's not something that by itself does prolong life. It actually can increase slightly your risk of death while you're on these medications. Any questions? So the way we do this is when we decide somebody needs this medication, we actually have you admitted to the hospital. You are in the cardiac intensive care unit in the hospital. On an average, I would say between 2 to 5 days. And we actually put a catheter. I don't know if you've ever been familiar with it. It's called a swan catheter. It's a small catheter that has a balloon at the tip of it. We insert it through a vein in your neck, and it basically goes down into your heart so we can measure the pressures in your heart and what the pumping function of your heart is. So we put a swan catheter, we measure the pressures, we measure the pumping function of the heart, and then we start this medication through an IV. And we titrate the dose. We want to give you the minimum amount of dose that you need for your heart. So we titrate it up to a stage where you're able to function, get more energy, there's enough blood flow going to all the organs in your body. And then once we get you to the right dose, you go home with this medicine. There's usually a pack like this. This is the pump. And you basically wear that pump around your belt, and you just walk around with it. There's a little IV that comes out of that pack, as you can see, and it's an IV that is inserted into a vein in usually your right arm, and you just go about your day. And so you have a pump you carry with you everywhere, and a continuous IV medicine is flowing through it, increasing the pumping function of the heart. On an average, I would say I have people on it somewhere not longer than a year. That's usually what I aim for. I have had one patient now who's had it for almost 2 years, but almost always that's a bridge to some other therapy. Sorry, you had a question.
How do you take a shower or a bath?
Yeah, so there is actually a plastic sleeve that they actually send home with you, and you can actually put that plastic sleeve on right where the IV is inserted, and you can shower and you can do everything. Yeah, you're still completely mobile with that device. Mm-hmm. You had a question, sir? Okay, so any other questions about naninotrope? So it's a great option. Again, it's you feel symptomatically like a whole lot better. I've had people, I start the medicine, the next day they're like, I'm done, my heart failure is cured. And I'm like, yeah, I'm sure you do feel that way, but you have to remember it's not a long-term solution. It is a good short-term bridge to do something else beyond that. Okay, but it is a common procedure, and we do it, I would say at this point through our clinic, we probably have had about 10 to 15 people on inotropes, so it's relatively common. All right. The next one is a little more advanced and a little more invasive. It's called a left ventricular assist device. How many of you remember Dick Cheney getting an artificial heart pump? It was very famous in the news and everything. So that's exactly what we're talking about. Some people describe it as an artificial heart pump. It's not exactly correct, but I will explain the difference. So in LVAD, what it actually stands for, left ventricular assist device. Now you remember from the first class that Dr. Kublivkar did, your heart has 2 upper chambers, it has 2 lower chambers. The main pumping chamber of your heart is the left lower chamber, and that's the part that pumps blood to the whole body. That is the part we talk about that gets really weak in advanced heart failure, because that left lower chamber, the left ventricle, is just not pumping enough blood. So what this device does, it's actually a little device that actually sits inside your body. This part of the device sits inside your body. It's actually got 2 arms. One arm that's sitting in that left ventricle, the main pumping chamber of the heart. Then there is a pump over here, and another arm that goes into your aorta. Remember, the aorta is the big blood vessel that's carrying the blood to the whole body. What this device actually does is it does the pumping function instead of your left ventricle. So because your left ventricle, that chamber of your heart, is not pumping, this device sucks the blood out from the left ventricle and pumps the blood into the aorta. So it basically does the function of what the left ventricle is doing. Because your ventricle is so weak, it's not able to pump. This does the pumping for you. Now, we have an example of the device I can show you. So part of the device, this part is the part that's sitting inside your body. You don't see this. This is what is implanted inside your body. One part in your heart, coming out from the heart, and another part going into the aorta. There is a catheter, which we call the drive line, that comes out of your body. That's this catheter. And that is what's connected to this power device over here. So this is the external part of your device. Matthew, do you mind just talking a little bit about how you are walking around with it so they have an idea?
Well, I got something different from what
it's slightly different what Matthew has, but
this is, I got to carry an extra controller around with me wherever I go in case mine goes out. This is what mine looks like.
Yep. That's the controller and the two batteries that it's attached to.
And the drive line actually goes into here. All right? And these lights will tell you if something's going wrong. And if it stays green, you're good to go. And you can't sleep with it with batteries hooked up. You cannot sleep. You don't hook up to a power cord at night to sleep.
Yep. Exactly.
What if the power goes out?
It's got a backup battery.
You've got backup batteries. Yeah.
So it will let you know to get up, get on batteries, sit up, and wait for power to come back on.
Yeah. So this technology has been around 10 years. So it's relatively new. And I would say the longest living survivor with this device is probably around 9 years old right now. So it's been around. It is available. I don't mean to scare you, but I want to mention a few things. So number one, this device, it's an open surgical procedure. When you implant it, the surgeon has to cut your breastbone, implant the device, and then, it stays with you until we decide you need like a transplant, or sometimes you do it as a bridge destination, which means you're not a transplant candidate for whatever reason, you live with it for the rest of your life.
Question, the device that you put in is the same size that you have?
Yeah, so the smallest device that's been approved, I think, is about 3 pounds, but on an average, I would say it's probably around that size. That's actually implanted into your body. And this is actually a lot smaller than when it was first, the first devices, they had to implant them in the belly because they used to be so big, they had no room to put it in the chest. So this has definitely gotten smaller, and as the new technology keeps coming through, it's going to keep getting smaller. That's what most technology does with machines, is it makes it smaller and smaller. But
I can add to what she's saying because I used to work transplant back in the late 80s, early 90s of my nursing career. And when they first came out, the machines that we used, the battery packs, they stood this tall, this wide. The patient was only allowed off the machine for 30 minutes, twice a day, and we had to push the big cart with the batteries on it to take the patients out for walks and things like that. And I worked on the hospital I worked at, we were a teaching hospital, and we did transplants all the time. We did lungs and hearts. So trust me, for what you see now and what they used to be, they've come a long way.
I'll pass this around, but this just speaks to what Dr. Tulsa was saying, is this is the old XVE model, and it was 2.5 pounds of titanium, and like she said, patients couldn't qualify for it because of the body surface area wasn't big enough to house the pump. And so we have definitely come a long way. This pump, the HeartMate 2, is about 1 pound in weight, but giving all the batteries and the system or pocket controller, it's about 7 pounds that the patient has to carry around the external device. So, but the pump itself is about 1 pound in weight. So we have come a very
long way. Yep.
So I don't know if that helps to pass that around, but the durability of this pump is quite sustainable compared to what the older devices were too.
Exactly. So we have people, at least now, good 10-year long studies that have shown people living with it. And so we use it in 2 settings. We use it either usually in young patients as a bridge to a transplant, even today. But in others, we use it as what we call destination therapy, which means you live with it for the rest of your life. And, we have had very good overall results with a lot of patients who've had it. I've been very pleased with how well they've been doing. Again, it makes you go about your day. I know you wear it. I mean, if any of you saw Matthew on the road, you would have never thought he actually is walking around with an artificial heart pump, but that's exactly what he has. And so, people go about their lives with it, and you kind of adjust to it. One of my patients actually told me it's like the first time he went home with it, it felt like he was going home with a new baby and he didn't know what to do. But you learn and you go with the punches and you figure out a way how you exist with it. And I couldn't have put it any better way, because it is a life-changing thing, and you really have to modify your lifestyle for it. But it definitely helps people when all other therapies have failed. So, questions?
I have a question. What about like scar tissue and infection?
Yeah, so let's talk about, so obviously any invasive procedure carries risks with it. So this surgery itself is a pretty big surgery associated with it, bleeding, infections, things like that. Most people, though, the surgeons are well experienced in this device and they do okay during the surgery. The bigger risk I have felt is in the long term with these patients. One big one is infection, because there is this catheter sticking out of you. You have to make sure that area is always very clean. Oftentimes people can get an infection of that drive line, which is scary, but we have seen it. So that is a real risk. Another big risk I have seen is patients, especially the HeartMate 2 and other devices. HeartMate 2 is better because you kind of have to use low-dose anticoagulation, which means blood thinners. But the minute you're on blood thinners, that has its own risks with it, because there's a risk of bleeding, there's a risk of stroke. Both of those are very real, and we do see that with patients who have this device. Another issue, this is much more to do, again, this is really important to understand. This device is not a replacement for your heart. A lot of people think this replaces my heart. This doesn't. What it replaces is actually one chamber of your heart, which is your left ventricle. And it really helps support that left ventricle. We do have people who have very high pressures in the right side of the heart, and those people don't do well with this device. So either they should not have qualified for it, or sometimes they do get better with time on the device, so we take a chance, but then the right ventricle still is failed. So those are some real challenges, because we are not supporting the right side of the heart. We're only supporting the left lower chamber, the main pump of the heart. So it works best in people, I feel, who have the rest of the heart is fine, their pumping function of that left ventricle is bad. So in that situation, I think this device works really, really well. But in others, there is some challenges that we kind of have to work around. So, but yeah, the other times, sometimes I really thought this device has helped is in people who've had heart failure for such a long time that it started affecting their kidney function, or it started causing high pressures in their lungs, or it started causing some congestion in the liver. Sometimes because of those numbers, they will not qualify for a transplant, so we put this device in, get their heart pumping better, all those numbers look better, and then we can bridge them to a transplant. So, there are certain areas that this device really has helped, and I think those are some of the examples for it. But it has its own risks. It is not without risks. It is a huge, even when things go perfectly well, it is a huge change in your lifestyle, and not just yours, your families and everybody, all your caregivers and loved ones. So it's not a simple decision. I'm going to make you talk a little later too. All right. So again, we talked about trials that's been going on for at least 10 years. It does show it can extend your life. Unlike the IV medicine, this actually does extend. There is a life prolonging measure here. And it also, most importantly, I feel, improves the quality of life in a majority of the patients. So that's, I think, much more relevant. Some data recently, the survival rates at 1 year was 85%. So you kind of have to remember, these are patients whose life expectancy at this stage without the device was less than a year. So when you're talking in those numbers, 85% of them with this device survived more than a year. And the 2-year survival was around 58%. Like we talked about, the smallest device right now that's FDA approved weighs 1 pound, 3 inches. We talked about some of the risks, such as bleeding, the infection, stroke, and when the right heart fails. Okay. The last bit I want to just mention real quick is heart transplant. Now, heart transplant sounds like this magical therapy, like great, I get a new heart and I'm done. Now I don't need to worry about anything. It does have some challenges and some real challenges. Number one, on an average every year, the number of donors in this country is pretty stable. It's pretty steady. That number isn't going up. It's 2,100 people. So that's the number of hearts we have that we get on an average every year to transplant. Whereas if you look, currently up to 50,000 people are candidates for a heart transplant. So you see the huge difference between the demand and the supply. We have 2,100 hearts available every year, and you have 50,000 people who could qualify for a heart transplant. So we're nowhere close to meeting the need of the population. That's why we do these other therapies to buy time, because most times we need time, because most people will never even get that heart transplant, you know. So there's a very careful selection process involved. I mean, it's such a limited resource that we really have to screen and make sure that's the ideal candidate. Some of the things we take into consideration are things like if you have any other diseases along with just the heart, like are you having kidney problems, are you having liver problems, people who have lung diseases, things like that pretty much automatically gets you, it's hard to get you listed for a transplant when you're dealing with all the other issues. And it's rare that, you have the heart failure just as an pure organ problem. Usually you have one or two other organs affected, then it makes you harder to get the heart. The other issue is, we talk about patients' weight. If you're too overweight or too underweight, that is an issue with heart transplant. We have to usually, the BMI, the body mass index, we usually want that to be at least less than 35. So that's one issue. The other bigger challenges is things such as getting the right blood group. In general, O positive blood group, which is among the commoner blood groups, you have the longest wait for a transplant, usually at least 2 years, even after you've crossed all the boxes. Others with the B positive, A positive may get it sooner, within few months, but it all depends on that. It depends on if you've ever had blood transfusions in the past and if you've built up antibodies in your body against other blood, because then that can make it harder for you to get a heart. So it is a real wait. When you do qualify and you do get the heart, that's fantastic. But again, the story doesn't end there, because even after you get a heart transplant, you basically have to be on medications that's going to suppress your immune system for the rest of your life. Because if your immunity is not suppressed, your body will start reacting against the new heart and start rejecting that heart. So we have to give you medications that really actively suppress your immunity, your body's ability to fight things such as infections and things like that. So here is just a quick graph. With the new immune suppression regimens, the survival has improved. Where a 5-year survival, we see about 73%, and a 10-year survival post-transplant of over 56%. So more than half of the people 10 years out are still living and doing well. This is the number of heart transplants we do. The United States is the one in red. As you can see, it's pretty steady, the number that we've done. There's not been a great increase. Like most of the medical technology, when you see the graphs, you're like, oh yes, we've done like 10 times as many. Transplants, the number has remained pretty steady over the years because the number of donor hearts we have is pretty limited. The wait times, we talked about how it varies between person to person. It depends on your blood group. It depends on the antibodies. It also depends on what your clinical status is. Are you able to walk around? Are you functioning okay? Or are you having an LVAD? And that puts you definitely in the higher category.